This is a video in clinical medicine from the New England Journal of Medicine.
Pelvic ring fractures are potentially life-threatening complications of high-energy trauma. The primary mode of death is hemorrhage from the pelvic retroperitoneal vasculature. Sustained hemorrhage can occur because fractures that open the pelvic ring increase the pelvic retroperitoneal volume. This creates a space that can accommodate a large amount of blood. Pelvic ring fractures are typically also mechanically unstable. This contributes to further hemorrhage when thrombi are disrupted during manipulation of the patient. Hemorrhage from pelvic ring fractures can be reduced by circumferential pelvic sheeting. This supports tamponade of the pelvic retroperitoneum by decreasing its volume and supports thrombus formation by mechanical stabilization of the fracture. The pelvic skeleton is formed by the paired innominate bones and the midline sacrum. Posteriorly, the iliac portions of the innominate bones articulate with the sacrum, forming the sacroiliac joints. Anteriorly, the pubic portions of the innominate bones articulate with each other, forming the pubic symphysis. Together, these bones form the pelvic ring, which provides protection for major vascular structures that pass through the pelvic retroperitoneum. The external iliac vessels travel along the innominate bones. The internal iliac vessels travel anterior to the sacroiliac joints, and the presacral venous plexus adheres to the sacrum. These vessels and their branches are vulnerable to injury when the pelvic ring fractures. The greater trochanter is the only palpable lateral projection of the proximal femur. This surface landmark is used to position the circumferential pelvic sheet. Circumferential pelvic sheeting is indicated for patients with high-energy fractures that open the pelvic ring and cause hemodynamic instability. Such fractures frequently result from antero-posterior compression. This force vector opens the pelvic ring by distracting the sacroiliac joints and causes hemodynamic instability by tearing retroperitoneal vascular structures. Circumferential pelvic sheeting is contraindicated if other life-threatening injuries take priority. This includes injuries affecting the airway, breathing, or circulation. It is also important to differentiate high-energy mechanisms of injury from low-energy mechanisms of injury. Patients with osteoporosis who fall from ground level can easily sustain pelvic fractures. However, these fractures rarely disrupt the pelvic vasculature. Circumferential pelvic sheeting is contraindicated for low-energy pelvic fractures because it can cause further damage to the osteoporotic bones. In contrast to antero-posterior fractures, lateral compression fractures close the pelvic ring by compressing the innominate bones and allow for tamponade of the pelvic vasculature by compressing the retroperitoneum. Therefore, lateral compression fractures rarely cause hemodynamic instability. Circumferential pelvic sheeting is contraindicated for fractures that are known to be caused by lateral compression because the concentric force from the sheet can worsen this deformity. The only equipment needed to temporarily stabilize a pelvic ring fracture is a hospital bed sheet. 4 large Kelly clamps can be used to secure the sheet. Alternatively, the sheet can be secured with a knot. Use of an X-ray machine is helpful to confirm adequate fracture reduction. Once the trauma patient is in a safe environment, systematic evaluation and resuscitation can begin. During the primary survey of the patient, airway management, ventilation, and the initiation of hemodynamic support take priority. The pelvis is subsequently addressed as part of the secondary survey. The history should elicit the mechanism of injury, including the direction of the force vector. Pelvic sheeting is most useful in patients with antero-posterior compression-type fractures. Inspection may reveal unequal leg length or rotational deformity of the legs. Hematoma of the flank, perineum, or scrotum indicates retroperitoneal hemorrhage. Deep lacerations, hematuria, or blood on rectal or vaginal examination indicate the presence of an open fracture. Physical examination serves to determine the extent of pelvic mechanical instability. Examine the extent of antero-posterior instability by compressing and distracting the innominate bones. Next, examine the extent of vertical instability by pushing the innominate bones cephalad, then pulling caudad. If the pelvis is unstable, either of these manipulations cause pain or movement of the innominate bones. It is important to minimize manipulation of the injured pelvis. Therefore, the examination should stop if mechanical instability is detected. At this point, the pelvis should be stabilized with a circumferential pelvic sheet if there are no contraindications. When appropriate, the clinical examination can be replaced or complemented by a pelvic radiograph. The examination concludes with an evaluation of the neurovascular status of the legs by palpating the femoral arteries and testing lower extremity motor and sensory function. These findings serve as the baseline for the detection of neurovascular compromise. In order to stabilize the pelvis, the sheet is folded longitudinally to a width of 20 to 30 centimeters. Wrinkles should be avoided to minimize the pressure on the skin. Next, the folded sheet is positioned under the exposed patient. Spinal precautions are maintained by log rolling the patient. The sheet should be centered at the level of the greater trochanters. If the sheet is placed too high or too low, the asymmetrical force applied across the pelvis can worsen the deformity. Since many patients with pelvic ring fractures have associated abdominal injuries, the sheet should be positioned low enough to allow for serial assessment of the abdomen and further interventions such as laparotomy. Once the sheet is in place, cross the ends anteriorly and pull tightly until the pelvic bones are reduced. Aim to deliver the primary concentric force of the circumferential sheet at the level of the greater trochanters. Finally, the ends of the sheet are secured with Kelly clamps. The tips of the clamps point laterally to avoid pinching the skin. If clamps are not available, then the ends may be tied in a knot. After securing the sheet, re-examine the neurovascular status of the legs to detect any neurovascular compromise. The most serious complication of circumferential pelvic sheeting is overcorrection of the fracture, since this can result in further injury to pelvic organs and neurovascular structures. Therefore, it is important to re-examine the patient after the sheet has been secured and obtain a follow-up radiograph as soon as feasible. If the fracture has been overcorrected, then the sheet should be loosened and radiographs repeated. Prolonged pressure from the sheet may also compromise the integrity of the skin. Therefore, wrinkles must be minimized and the sheet applied over a broad area to distribute the pressure on the skin. The sheet should be removed as soon as definitive management of the fracture is possible. This should occur within 24 hours. Pelvic ring fractures warrant urgent transfer of the patient to a trauma center. Definitive management of the fracture involves skeletal stabilization with either internal or external fixation. Definitive management of continued hemorrhage involves angiographic embolization or surgical packing. Circumferential pelvic sheeting is a simple yet potentially life-saving intervention for high-energy fractures that open the pelvic ring and cause hemodynamic instability. The folded sheet is centered over the greater trochanters, crossed anteriorly, and then pulled tight. The ends of the sheet are secured with clamps or a knot. Complications are detected by examining the patient and obtaining a follow-up radiograph. Patient should be transferred to a trauma center for definitive management.